Welcome to the fourth US sonar video demonstration for scanning the shoulder, and we'll start by scanning the anterior aspect of the shoulder. Place the transducer across the front of the shoulder, and as you can see on the ultrasound image, what you're trying to see is the biceps tendon, and you will need to rock the transducer to make sure that the biceps tendon is bright. If it's dark, then you cannot distinguish a normal tendon from fluid, or an anisotropic tendon is what you're seeing. So rock it until it is about as bright as you can get it. Then you can tell the distinction between the tendon and the tendon sheath. You'll want to image the tendon within the bicipital groove, and as I'm scanning down caudally, notice that I'm having to rock the transducer more to keep that tendon bright. You can see the transverse humeral ligament that keeps the biceps tendon in place. Notice that there's no fluid around the tendon, and I'm going to continue to scan down the tendon until I reach the pectoralis tendon insertion. Once I get to that location, I've scanned distally enough to see a biceps tendon tear if I'm going to see it. Also, fluid will sometimes gather down at this distal edge of the biceps tendon sheath. And then I'll come back up until the groove just disappears. There's no need to follow the biceps tendon in the intra-articular space. Once you've imaged it in this transverse plane, go ahead and change the transducer to a longitudinal plane and find the biceps tendon. The easiest way to do that is if you start laterally, you'll see this bone. This is the greater tuberosity. As you scan medially, you'll see these fibrillar fibers. You'll know that's the biceps tendon. If you go further, they'll disappear and you'll see the lesser tuberosity. So this is sometimes called the tendon between two mountains. So here's one mountain, here's the tendon, here's the other mountain. So right between them is the biceps tendon. Here you can see the fibers of the biceps tendon proximally, but not distally, so I'm going to have to adjust the distal edge of the transducer. So I'm going to turn it on its axis until I can see the fibers go distally. As the biceps tendon is moving away from the surface of the skin, you'll notice some anisotropy. So I'm going to, what we call heel toe the transducer. I'm going to push in with the distal edge of the transducer until the biceps tendon is parallel with the face of the transducer. Then you'll be able to see these fibers most brightly and see that they are not torn. Notice that the biceps tendon does not hug the bone as the humeral head moves towards the neck. There is some normal fatty connective tissue that sits between the bone and the tendon. So don't call this tendon. That's the tendon. It has those nice striations. Once you've imaged the biceps tendon, you can go back to the top, turn back to a transverse position, and again, medial is going to be on the left side of the screen, so this is going to be the lesser tuberosity on this side. And I will use the lesser tuberosity as a landmark for finding the subscapularis tendon. Here you can take the patient's hand and externally rotate it, and as you do so, the subscapularis tendon will come into view nicely. So you can see this is the attachment point of the subscapularis tendon onto the lesser tuberosity, and all of these fibers look quite good, and scan up and down to go through all of the layers of the subscapularis. If you go more medially, you will also notice the coracoid process more medial than the subscapularis. Sometimes you will see a bursal effusion between the deltoid and the subscapularis, and frequently that is seen near the coracoid process. This is a transverse view, so now we'll, or the longitudinal view to the subscapularis will then turn in a transverse or short axis to the subscapularis, and you'll see that it has many fascicles. So here's one, here's another, here's a third, and if you rock the transducer, you'll see that subscapularis tendon turn from dark to bright. It should be all one thickness, and you can scan back and then closer to the insertion. So that's the subscapularis, and you're ready to move on to the infraspinatus. For infraspinatus, I'll turn the transducer in the opposite direction and scan laterally. So here is the greater tuberosity, and that's where the infraspinatus inserts. So as I come posteriorly, I will see the insertion of the infraspinatus on the greater tuberosity, and I'll follow that posteriorly until I'll see the transition from the infraspinatus tendon to the infraspinatus muscle. So the infraspinatus tendon, you can see the attachment to the posterior part of the greater tuberosity. Notice that the transducer is going to be relatively parallel to the scapular spine, and I'll slide it right along that scapular spine until I see the transition from tendon to muscle. Here we'll need to make some equipment adjustments. I'm going to bring the depth to a deeper setting so that I can see both the humeral head here and the glenoid down here. And since our focus is now down deeper, I'm going to bring the focal points, here they are, I'll bring them down to the region of interest. Notice how the brightness of the labrum changes as the focal points go from a more superficial to a deeper position. Once you've imaged the glenoid, the labrum, and the humeral head, you can look for any effusion of the glenohumeral joint. In imaging for effusion, you're looking for an anechoic dark structure to push away the infraspinatus muscle. And to have the best chance of seeing this, you will want to hold the transducer in one hand while you hold the patient's hand in the other, and you gently externally rotate while watching. In full external rotation will give you the best chance of seeing a glenohumeral effusion if it's present. Notice the infraspinatus tendon is right above the arrow, and that moves back. You can see how that infraspinatus muscle is pulling, externally rotating the humeral head. Also notice that the labrum, which is nice and bright here, hugs the humeral head. It does not bend backwards, and you might see it flip backwards if there were a labral tear. So now we've imaged the infraspinatus tendon and the glenohumeral joint, as well as the labrum, and we can move on to the AC joint. For the AC joint, you can palpate it anteriorly and put the transducer right down on top of it. This is much more superficial, so again we're going to have to make some adjustments to our setting, decrease the depth maximally, and bring our focal points back up. So here you're seeing the AC joint. This is medial, so this is going to be the clavicular portion, this is going to be the acromial portion, and this is the capsule over the top. Notice how flat it is, it's not bulging out. You could see some calcium deposits within the AC joints in this region as well, and you might turn on Doppler to see if there's any hyperemia. Very easy scan to do. Just make sure that you're anterior enough, because if you put the transducer more posterior, you will not see the AC joint. The last view, or the view that I generally save for last, is the least comfortable for the patient with shoulder pain, and that is the CRAS position. For that position, you'll want to take the arm and put it behind your back and put the back of the hand across the lower back. What this does is it maximally internally rotates the arm and brings the supraspinatus tendon out from underneath the acromion to its insertion on the greater tuberosity. Put the transducer then one edge on the acromion and one edge pointing straight down to the insertion of the supraspinatus tendon. Again, I'm going to make an adjustment to the depth, and just so we can see fully the supraspinatus tendon. Notice this is the articular portion of the humeral head. Here's some hyaline cartilage. This is the footprint, so there's no hyaline cartilage here. This is where the supraspinatus tendon inserts. And you'll want to see these nice striations of the supraspinatus tendon all the way to the insertion. Some people describe this as a beak shape, so perhaps a raven's beak. It has a curve to the top of it. If that curve flattens out, that would be indicative of a supraspinatus tear. So here's one slice I'll go ahead and slide the transducer medially until I lose it, and then start sliding laterally again until this footprint portion of the humeral head disappears. Now I know I've scanned through the entirety of the supraspinatus tendon. This very thin dark line is the subacromial bursa. Normally it's barely visible. If there's a subacromial bursa effusion, this will become much thicker. Don't make the mistake of calling these dark, deep sections of the deltoid the subacromial bursa. Notice that the bursa will track down to and below the acromion, whereas the deep portions of the deltoid will layer to the top. Also, the subacromial bursa will stop normally at this distal insertion of the supraspinatus. If there's an effusion, you may see a drop of fluid distal to this point of the greater tuberosity. So don't forget to look just distal to that point as well. So this is the longitudinal view. For the transverse view, generally we'll switch to what's called a modified CRAS position. In this position, the arm is positioned with the hand in the back pocket and with the elbow pointing straight back. And this puts a little bit less tension on the supraspinatus, puts in a little bit less internal rotation, and what this allows you to do is have a better chance of seeing the biceps tendon. Here's the biceps tendon. And the reason you want to see that is it marks the most medial aspect of the supraspinatus tendon here. This is the rotator cuff interval between the supraspinatus tendon and the subscapularis tendon. The biceps lies in that interval, and if you can see that, that's a landmark to tell you, yes, you are indeed looking at the most medial fibers of the supraspinatus tendon, and those fibers are important because they're the ones most frequently torn. In this transverse view, the supraspinatus tendon is generally the same thickness throughout. It should not be thinner on one side than the other. If you have the transducer positioned not directly across the tendon, you will notice here the tendon is thinner, here it's thicker. So I'm going to straighten out the transducer to be transverse across the tendon, and unlike the CRAS position view, the modified CRAS position, the transducer is pointed at a 30-degree angle from up to pointed towards the xiphoid process. Okay. Again, if you wanted to see the subacromial bursa, here it is. It's very thin and barely visible just between these two hyperechoic lines that mark its superficial and deep portions. And as I scan distally, it disappears. As I scan proximally, it gets thicker and thicker and thicker until your transducer runs into the bone of the acromion. Then you've gone too far. And that's the exam of the shoulder.